All right, my name is Mark Yakavonis. I'm going to talk about chronic ankle instability. So what is ankle instability? Well, at a patient level, it's the sense that your ankle keeps giving out when you're doing activities. At a fundamental level, it's an injury to the lateral ankle ligaments, making them loose or lax so they aren't functioning properly. Who's at risk to develop this? Well, obviously somebody with a history of an ankle sprain, and a severe ankle sprain is a period of time where you're not able to walk after that sprain. You're also at risk if you have a high arched foot. So people with a high arched foot tend to overload the lateral aspect of their ankle and place a lot of stretch and strain on those ligaments. People who have generalized ligamentous laxity. So these are people with conditions like Ehlers-Danlos or other associated collagen vascular diseases. Obviously, if you play a high-risk activity, so paddle tennis, tennis, basketball, volleyball, these are all pivoting activities that are reactionary and can cause a lot of stress and increase your risk for an injury. How do you know if you have instability? Well, again, the hallmark sign for patients is they feel like their ankle is giving out. So, but in addition to that, a lot of times patients will have pain. And the question is, well, why would I have pain unless I'm spraining my ankle? And that's because recurrent sprains in the ankle can also cause associated conditions, whether that be injuries to the cartilage, swelling in the ankle causing a pinching or an impingement, or even arthritis. The ligaments involved in chronic ankle instability are typically on the outside of the ankle, and these are three ligaments. It's your anterior talofibular ligament, your posterior talofibular ligament, and your calcaneofibular ligament. The most common ligament involved is your anterior talofibular ligament. That's the one in the front. Now, it's also important to know that there are two ways to stabilize your ankle. There are static stabilizers, which are bones and ligaments, and they're either there or they're not there. So if they're injured, there's not a lot you can do to strengthen them other than to repair them. However, you also have dynamic stabilizers, and that's your muscles and tendons, and you can work on strengthening those, and they can actually improve your ability to stabilize your ankle. When I see a patient in the office who has a feeling of their ankle giving out or has some instability, the first thing I look at is their foot alignment, because as I mentioned, that you can have a high arched foot, which can increase your odds of having ankle instability. I also look at their gait, and I make sure that they have good ankle eversion strength, so their peroneal muscles are strong enough to prevent them from chronically inverting. I'll also perform a stress exam, and I'll get into a little bit after that what that involves. And then also do what's called a Beighton score. And that is a score to test for generalized laxity. And again, it tests the strength of your ligaments and the quality of your ligaments, and that's on a general sense. So again, if you're generally lax, you might be more inclined to have this sense of instability. So here's an example of a stress exam. So there are two stress exams that I do. One is called a talar tilt, and that is on the right side of the screen. And that's where you put a lateral directed force about the medial tibia, and then you invert the ankle. And then the other one is called an anterior draw, and that's where you put a posterior directed force on the anterior tibia and translate the ankle anteriorly. It's important to compare this to the other side because sometimes it might feel a little bit loose on both, but if it's more on one side than the other, that's an indication that there is some instability. It's also important to note whether or not there's an end point. So sometimes with lax ligaments, when you reach an end, it's not clearly defined and instead has a little bit of play. I also routinely obtain imaging. So it's important to get weight-bearing x-rays of the ankle to assess for the foot structure. But it's also important to look for associated pathology. And I also do stress radiographs. So similar to the provocative maneuvers I discussed earlier, I also do those under fluoroscopy. And you can see the results of these. So on the right side of your screen is the anterior draw test. And so you can see that the talus, which is the bone sitting underneath your ankle, translates anteriorly in your ankle. And then the other one is a talar tilt. So again, you can see that it's wider on the outside of the ankle joint rather than the inside of the ankle joint. And so these are important tests to determine whether or not you have instability. But it's also important to understand a lot of times patients will have pain when you do these stress exams. So you need to watch out for false negatives. I routinely obtain MRIs prior to any intervention for patients that have ankle instability, and the reason for that is to look out for other associated conditions. So there are a few different conditions you can develop. Most commonly, a lot of patients will have synovitis. So if you have chronic inversion to your ankle, you'll develop a lot of swelling and that can cause pinching in your ankle. But you also want to look out for things like osteochondral lesions, which are injuries to the cartilage. So if you're having repeated ankle sprains, you are likely to develop an injury to the cartilage, and that's why we want to do something. And then also, as I mentioned, there are dynamic and static stabilizers. So if your static stabilizers, your ligaments aren't functioning properly, a lot of times your dynamic stabilizers, your peroneal tendons are working overtime. So you're more likely to develop a tear or tendinitis or some issue with your peroneal tendons. How do you treat ankle instability? Well, there are really two ways, non-operative management and operative management. So again, I mentioned that there's really nothing you can do to truly correct your ligaments or your static stabilizers outside of surgery. But you can alleviate symptoms and you can prevent the recurrent sprains. So how do you do that? Well, the hallmark is strengthening. So this is an example of how you strengthen your ankle. So you get a rubber band, you attach it to a doorknob, and then you do eversion stretches and inversion stretches. And this slide shows that very clearly. And what you can do on your own is do it 10 to 20 times for 3 to 6 sets a day. And by strengthening your ligaments, strengthening your tendons and muscles around the ankle, a lot of times you can prevent that recurrent sense of your ankle giving out. It's also important to work on proprioception. So that's coordinating with your mind and your muscles when they need to fire when your ankle's in a certain position in space. So the way you do that is by standing on one leg for about 30 seconds, 5 to 10 times a day. And you do this in a staged manner. So the first stage is just standing on one leg on even ground. Then you graduate to doing on uneven ground. And then you can try to do dips. And if you can coordinate this brain to muscle system, well, then you can also prevent this recurrent ankle giving out sensation. Now, physical therapy is also very beneficial, and that's for two reasons. One is they can push you a little bit beyond your comfort level if you can't do this on your own. And two is they make sure you do your homework and you're doing your exercises on your own. Splinting is another way to prevent chronic ankle sprains. And you can do this by taping. You can also get a lace-up ankle brace. So on the right side of the screen, you can see a lace-up ankle brace, and that's my favorite brace. I tend to be less reliant on taping, and the reason for that is I think tape can give out and lose some of its integrity over the course of a game or a practice, and that's why I think the brace plays a larger role. What happens if you try bracing, you try therapy, you try stretching on your own, and you still have instability? Well, that's when we move to a more aggressive option, which would be considering surgery. And there are two ways to treat this surgically. One is a ligament repair, and the other is a ligament reconstruction. And this partly depends on the quality of your tissue, whether or not it can be repaired. Here's an example of a ligament repair, and what you do is, again, the most commonly affected ligament is your anterior talofibular ligament. So what you do is you reflect that ligament off of the fibula, and then you tie it down in a tighter manner back to the fibula. So you can see here illustrated, you reflect off the ligament and then tie it down and imbricate it in a more taut position. Unfortunately, not everybody is a candidate for this, and sometimes the quality of your ligament will not allow you to have it repaired, and that's a ligament reconstruction. And basically what you do is you either take a cadaver tendon or a tendon from elsewhere in your body, and then use that tendon to then reconstruct the ligaments. And what you do is you plug it into the anatomical insertion sites, and this can augment a deficient tissue that you have in your ankle. The rehabilitation from both of these surgeries is quite long, and that's the reason for that is to get soft tissues to heal, it can take many months. So initially you're in a cast non-weight bearing for about 6 weeks, then you start physical therapy, you transition to a walking boot, and then usually return to play, unfortunately, is sometimes delayed up to 6 months. It's somewhat controversial whether or not this can be done arthroscopically versus open. It's sort of up in the air and it's surgeon preference. There are pluses and minuses to both. So if you do it arthroscopically, obviously the incisions are smaller, but there's a higher risk for nerve injury. If you do it open, the surgery is quicker, but you have a greater morbidity associated with a larger incision. Some new updates that have come along in terms of lateral ankle ligament instability is something called an internal brace, and this functions similar to as the name would imply. So while I said that your soft tissues take a long time to heal, so it can take up to 6 months to heal, the principle behind this is that it's a suture that will provide an internal restraint to prevent your ligaments to stretching while they're healing. And the advantage to this is that it will allow for earlier recovery time. In addition, I mentioned that there are a lot of comorbidities associated with chronic ankle instability. So whether or not this is a injury to the cartilage, injury to the peroneal tendons, there are sometimes other procedures that your surgeon will recommend for you. One is synovitis. So if there's synovitis, you can remove the synovitis, and you do that arthroscopically. You can also address injuries to the cartilage arthroscopically, as well as you can directly address injuries to the peroneal tendons, whether or not that be to fix them or to debride them. One other thing that might be recommended is some people with a very high arched foot might be recommended for a foot reconstruction. I think the principle behind that is a little bit beyond the scope of this talk, but you do need to address the cause of your ankle instability as well as the instability itself. Thank you.